I guess in the name of time, we'll keep moving. So grateful to be here. Wonderful city. Appreciate everybody participating. It's a wonderful opportunity to share. I see a lot of friends, Peter from Medtronic and from Medela. We have Tobias, and we're grateful for, for all that support that we have to do this. I represent the ERAS Cardiac Society and grateful to the leadership of the International Coronary Congress, Gianluca, the others, for this inclusive, interactive leadership and an opportunity to talk about these innovative type things. Tom suggested, parenthetically, we trained together and we've been at this now as very close friends for, 33 years? So it's a great opportunity to share the podium and really see not just where we've been with things like enhanced recovery, but where we can go. With that, I think our first speaker is Rakesh, who's also representing enhanced recovery after cardiac surgery. Maybe the one saving grace in all of this, and an apology in advance, is Penny was not able to join us because of illness, so we'll do our best to try to catch up. I think that the more German like people in the audience like myself are probably a little chest pain being 30 minutes over, and maybe our Italian and Spanish friends aren't so upset, but we'll try to get back on track.
Thank you very much, and again, thank you to the Society for giving us the opportunity to present today. My task is to start this session as the lead-in to all the great talks you're going to hear to talk about the state-of-the-art of cardiac surgery enhancing recovery programs. These are my disclosures. I'll talk a little bit about some of these topics, but nothing specifically to any particular company, and I'm always looking for more disclosures if anyone wants to fund our research. So let me start a little bit with the why this is important. We had a really great session yesterday where we went through secondary prevention measures and other medical therapies for optical therapy in a patient undergoing coronary bypass grafting procedures. And really what we're trying to accomplish is reduction of complications that occur after a routine procedure, regardless of the technique and approach that we take. Despite our best efforts over the last 30, 40 years of advancing the intraoperative components, complications still remain quite common, involving multiple different systems in the body around the course of their operation. How common in this? Well, if you look at in the United States, it's a paper from a few years ago now, but looks at the overall level of morbidity and mortality after cardiac surgery, particularly coronary bypass grafting surgery. So looking at all comers, thankfully mortality continues to be low and continues a downward trend despite an older and sicker patient population that we're dealing with on a regular basis. However, complications or morbidity still remains quite common, about 1 in 10 or higher of our patients. Importantly, this leads to not only their index admission, but high rates of return to senders. So we're coming back to the hospital for readmission for a number of different complications that can occur there afterwards. Importantly, the more complications you have leads to longer length of hospital stay, less good outcomes in your patients, and increased healthcare cost. And not all complications are the same. Some are weighted a little heavier than others, such as post-op atrial fibrillation or prolonged ventilation. But in essence, the more complications you have, the more likely you're going to have a negative outcome and a higher rate of readmission. This occurs not only in the short term, but into the long term as well. Starting first with a short term, this is a relatively difficult table to read through quickly, but I'll distill it down to the essence that when a patient does bounce back to hospital after complication for cardiac surgery, they tend to stay in your hospital for a while, 5 to 6 days as a median overall for the first readmission, with an increased rate of mortality, doubling the mortality what they would have had from their index cardiac surgery operation, with increased costs that go with it. So not inconsequential. Importantly, this has a long-term consequence for our patients as well, not just in the first few days or a month after surgery, but for several months to years thereafterwards. Again, the more complications you have, the less likely you're going to go home and be functionally independent, or worse, have a mortality. Looking at this house infects median survival, you can see that, again, distill this graph into a table shown for you with the column on the far right, that the increasing number of complications has significant reduction in your overall long-term survival. So how do we address these problems? And I think this can be distilled into broad categories shown for you on this slide. I'm going to focus primarily on the enhancing recovery elements for the purposes of this talk to set the stage for this session. For those who are not aware, we have now 2 documents that have been put out providing recommendations in a stepwise fashion to address vulnerability in our patients undergoing cardiac surgery. This is the most recent one that came out in January of this year, presented initially at the STS meeting, and the QR code's for you there. For those who are not familiar, please scan it and it'll take you to an open access article that you can read. I'll break this down into 5 key components, talking a little bit about why we did this, how this was a multi-society and international recommendations, how the document's structured, provide a practical example of how to use this in real terms, and where we're going in the future. And again, as we're going to hear in our next talk, unfortunately, one of our speakers is unwell, but this was really an interdisciplinary effort with Mike Grant, who is a cardiac anesthesiologist, intensivist at Johns Hopkins, and Cheryl Krasafi, a nurse ERAS coordinator at Bay State, with Dr. Dan Engelman, were really the leads for this particular document, and really forms the nature of what this has to be. Is it's a team sport that has to address everyone from the preoperative clinic to discharge planning and so forth. The overall goals of this is really trying to avoid this problem. So typically our patients come in with some degree of cardiac problems, that's why they're seeing us, and they may have some frailty, as we heard from Dr. Meha yesterday, where that make their outcome worse postoperatively. Invariably, there's a predictable drop in their function after surgery, and we work our best to get them up moving, starting their diet, to get them back to a regular quality of life, and ideally above where they start from before they came in for the heart surgery. The reality is that our patients who are older and sicker often don't get back to that baseline, and they may have a very prolonged recovery over the next several weeks to months thereafterwards. What the Enhanced Recovery Program tries to do is refill their fuel tank of physiologic reserve before they undergo the stress of surgery. Again, whether it's minimally invasive or not, it's still a large operation for the patients, where that drop in their function is lessened and their recovery is expedited, and hopefully to a level well above their baseline now that we've corrected their cardiac issue. So again, this was a multi-society endeavor that involved the ERAS Cardiac Surgery Society, the Society of Thoracic Surgeons, and the ERAS International Society, with representation from each of these groups as part of the writing committee. And it's structured into these 5 broad categories. There are some recommendations that are general for all patients undergoing cardiac surgery. Then they're divided up into the various phases of care: preoperative, intraoperative, postoperative, and some that may go across multiple zones of that particular patient journey. Each section is structured around a specific topic, and then there's a synopsis of the best available literature we had that informed our recommendation. There's a statement and then a quality of evidence for each one that you can see here. This one's for pulmonary artery catheter, to go to a talk we'll have later in this session. I'm going to give you a practical example of how to use this. We've talked a little bit about post-op atrial fibrillation in the last session and other sessions before. Oh, I lost my slides. I'll carry on. I'll wing it until the slides hopefully come back up again. So each of these recommendations have a challenge in how you actually implement it. And again, in this great session we had yesterday around optical medical therapy, we're talking about very complex maneuvers for our patients. Oh, okay, thank you. I'm going to just advance ahead. Sorry to make you all nauseated by doing this as it goes back to where I was. Best laid plans with technology, I guess.
Need AI.
If this is annoying for you, it's equally annoying for me, just so you know. Okay, I think we're back to where we were. Okay, so let's talk a little bit around postoperative stroke as one of the major dreaded complications after cardiac surgery. And this can be divided into early versus late. And when you look at some of the great work done again by yet another great paper by Mario Godino and also by Richard Whitlock, there are several reasons why postoperative stroke can occur, one of which is postoperative atrial fibrillation for delayed strokes to occur after coronary bypass grafting surgery. There are 3 broad categories in terms of recommendations of how best to treat this, with pharmacologic and non-pharmacologic atrial fibrillation prophylaxis, anticoagulation, left atrial appendage clipping, and so forth. How do you do this practically? Well, it really comes down to how you execute this plan with your team. So taking these guidelines now and putting it into knowledge translation that is practically implementable for you is something we've worked hard at over the last 18 months to provide these opportunities for you. We've termed these turnkey order sets, and really what this is trying to do is looking at all the best available evidence that's out there from various society guidelines and distilling them down to the Class 1 and Class 2A recommendations, sometimes Class 2B recommendations, and used our own subject matter experts to develop these order sets or recommendations. One example here, again, is for post-op atrial fibrillation. There's a QR code you can scan that will take you to the document that I'll show you in just a moment. But essentially what it's trying to do is divide the best practices into the 3 phases of care again, in terms of looking for appropriate risk and prophylaxis in the preoperative phase, intraoperative maneuvers, which includes doing maze procedures or left atrial appendage ligation, and how we best treat these patients post-operatively with appropriate beta blocker and amiodarone for prophylaxis. We then turn this into an actual order set that you can just take home and put this into your EMR tomorrow, or work with your teams to develop this that is scaled to your particular clinical context. It's small intentionally, so I'm going to take you to these QR codes. We now have 6 of these, one for how to do preoperative medication hold, patient blood management, or PBM, multimodal analgesia, and there was a great session yesterday in the other group with perioperative sessions with Dr. Bott and Dr. I forget the name of the other anesthesiologist, but great talk. AKI, surgical site infection, and then the bottom corner is postoperative atrial fibrillation. So where are we going to in the future? Well, I think much we've heard in the last session, we have to work more towards minimally invasive surgery. I think minimally invasive surgery and ERAS really need to be synonymous. You really can't have one with the other. Doing other processes to get us out of the ICU quicker, de-escalating, such as drain management and medications and mobilization. And then perhaps for a category of patients we may not traditionally think as being an enhanced recovery capable patient, those being under mechanical circulatory support. And as we're moving into an era that Roberto LaRusso is trying to push it into a protected cardiac surgery, we're using TMCS devices as part of our armamentarium to protect those patients undergoing CABG with low EF. It's an area that I think we need to think about logically as well. All this said and told, this is a lot of work done by very smart people over an 18-month period who are really true believers in this. And I think to try to implement this in your own team is a bit of a long road and does require interaction with your entire interdisciplinary team. There are all these complications occur. Each one of these can be a talk in of itself for an hour. So we really try to distill this down very quickly. But to summarize, basically, complications are common. They have both short and long-term impacts. We need to find improvements to identify risk before they have the risk of complications, or if they do have it, how to mitigate it as quickly as possible. And it really requires the whole team to be part of that process. And so while this may seem very daunting at the outset to steal, obviously I'm in England, so I had to use a Winston Churchill quote, that every opportunity that looks to be a challenge every barrier that looks to be a challenge is an opportunity to engage your team as part of this. So really think of ERAS as best practices, or even at the extreme case, a patient safety issue, and how you can engage your team in those regards. Again, the next talk was supposed to be about interdisciplinary teams, but we'll perhaps talk about that in the panel session. And with it, I'll try to get us back on time, and thank you very much for the opportunity today.
Rakesh, that was a great summary and comprehensive discussion of the opportunities and the need for innovation and thinking out of the box as to how we move our discipline to a higher level and serve our patients. So in the spirit of continuing the topic of innovation, our first abstract is going to be impact of rapid recovery after cardiac surgery on patient survival, 5 years following the implementation of the ERAS culture, by Dr. Omar Mahaya.
Good morning. Thank you for having me in this important discussion. Thank you, Kevin, Thomas, Rakesh. It is our project started in Brazil. I declared that I have no conflict of interest. This is in our scenario, the arrival of ERAS in cardiac surgery, more or less in 2018. And we have a hospital total core in São Paulo. It is a hospital STEs and Joint Commission database. It has part of ECTs. It's the only hospital in Latin America. It has part of ECT's national database. It's our group. It is a field report about the 3 days discharge is safe and effective, its potential to leave the patient in the hospital. These are validated by Chris from Chicago to it's possible to have a patient with discharge of the hospital with 3 days is safe and effective. This is our first workflows in the world. It's from São Paulo. We have a perioperative modification related to preoperative education of the patient, rehabilitation, use of pre-analgesic with pregabalin, for example. In the other processes similar to Rakesh showed for you. It is the test, the important and fundamental test to the patient leave the hospital in the 6-minute test, working test, in the different patients independently of the this is a second patient, for example, 77 years old with a cage on Pampi. It is the other patient with 66 years. This is in 2018 to 2019. This is our publication with 3 days is potential safe and effective to this patient. But we have problems with compliance because some elements important is not achieve 70% of the adherence. But in this editorial of Olay is the father of the ERAS concept in the beginning in the colorectal surgeries, is explained about this reduction in complications, 30 and 40% in the number of complications, recovery time, but recent data suggests benefit in survival in colorectal. These are published in 2019. But this is very important because we think about this analysis in our patients. Is the objective of this presentation is evaluate the impact of this protocol based in ERAS on survival of patients 5 years after cardiac surgery. We started in 2018, ERAS culture implementation in all hospitals is the STS adult cardiac surgery database. We have 480 patients. We excluded aortic surgery, combined surgery, and patients with complications, STS complication at the hospital. We have 2 groups, recovery time before 5 days, up to 5 days discharge at the hospital. In the other group, after 5 days at the hospital. We have launched a questionnaire to the patient. We have 338 interview to the patient, and we have made a propensity score matching adjusted to 10 categories in STS risk group to compare it between both groups. And by type of procedure is very important to adjust in this analysis. We have 169 in the first group, up to 5 days in discharge at the hospital. In the other group, we have 132 patients to compare it to in propensity score matching with 10 risk categories and by type of procedure. We have more complications in this group of patients. We have more than 5 days with acute renal problems, atrial fibrillation, infection too is important to consider. We have more complication in this group. But when we analyze about until 5 years, we have hospital readmission reduced in patients with leaving the hospital up to 5 days, 70.36 versus 30 0.11%. Is significantly. And the mortality of up to 5 years is in this graphic where you can see. In the blue line, we have this patient leave the hospital after 5 days. It's 25% more increase in survival in this graphic. But the more important, because ERAS is just not only a protocol, ERAS is a team building. It's very important, the compliance and effectiveness of elements of ERAS protocol. It's very important to relate it with a platform that is for accompanying to the adherence to these elements. It is a program in Brazil. We have escalating and scaling and sustainability the project in our hospital. But we have in São Paulo, we have a population of 41 million of inhabitants. We have 6 big hospitals. We started this project is comparing in randomized cluster groups in 6 big hospitals with platform to reduce time of period of internation with the patient. In conclusion, our data is in an ERAS scenario after implementation the ERAS at the hospital and comparable patients. The rapid recovery is postoperative time up to 5 days is also associated with increase in the survival 5 years after cardiac surgery. ERAS is not just a protocol, it is a commitment to effectiveness of the perioperative process in cardiac surgery journey. Thank you very much.
Those are some great results, and it shows the need for potential reevaluating some of our very principal assumptions that we've been basing our care for at least 20 years, and it shows the opportunities that are ahead of us. So in that same spirit, we are going to move on to the next abstract. It's titled, Unveiling the Impact of Drainage Tube Removal on Atrial Fibrillation Post-CABG, a Decade of Drainology Insight. And again, it's sometimes important to pause and to reassess our very fundamental assumptions as to how they might open up value for our patients.
Good morning. It's an honor to be here. ERAS is a very big topic, and what I'm trying to say here today is just a small part of it, the drainology. And the total core is really a good overall perioperative care, I think. But of course, there'll be a lot of problem because you get grumpy nurses and agitated anesthesiologists because a lot of work to do. Anyway, I'll start my topic today. We know that when we do heart surgery, this is what we get. Every single patient, they will need a drainage, basically. And so we know we have to put it in, but when do we take it out? Okay, the ERAS requires us to get an early removal of the chest tubes, early mobilization, and limited use of opiates. But pericardial effusion is actually very common. Back in Mayo Clinic, in a paper back then, it was 1.5% recurrent of pericardial effusion with lead pericardial synthesis. And from Charité Berlin, it will be 30% of effusion and 11.1% that requires for secondary drainage. These are 2 very famous centers, and yet the incidence rate remains very high. That means that it doesn't really matter. It matters how the surgeons do, but still, it's a very common situation that's happening. I'm a big fan of the active clearance system. Not a single patient with, a surgeon that has never met with a pericardial or pleural effusion throughout their whole work. And of course, adequate blood evacuation, we get quick recovery. And if there's happening of hypotensive, high CVPs, we get tamponade. And as in the most of the patients that we get is in the purple area with the left of the retained blood and causing the inflammatory cytokines that possibly causes the postoperative AFib. Of course, if we somehow still miss the boat, it will become constrictive pericarditis, and even worse, that needs a major surgery in the future. So when you lump all this together and you look at the large administrative database, it's actually very common, and normally surgeons always leave the OR, we say that we did a great job and everything is fine. But actually from the database, we see that it's still not enough. We got patients documented for 16 to 23%. It's a very high amount of patients. And if we leave the retained blood, we get what they call the ripple effect. So once this like POAF or stroke or AKI or anything that happens, it will be significant hospital resources we need to take care of them. And it will increase mortality, morbidity, and cause much more cost on the consequence. To us, paracentesis and torosynthesis may not be a big deal, but for patients, it hurt them a lot. And so we now identify that the retained blood around the heart is associated with the post-op AFib. So we need to find a way to clear that up. And this is the overall rate that happens after cardiac surgery. And in CABG is about 20% high. It increased stays for us, increased discharge readmissions, and a lot of medical liability costs. The ERAS of cardiac surgery is different from the thoracic part. Thoracic, they got a very specific, we hope to have a specific drainage volume to get, but the thoracic say is 450 milliliters, but for us, we don't have specific numbers to get that. When should we take off the tube? We just say 24 hours, 48 hours. It's still very unclear. We still see a lot of patients having this post-op AFib or necessary for paracentesis and torosynthesis, meaning maybe we are still not doing the good job enough. So whether leaving it for longer or is it rapidly removing the chest tube is equivalent or superior to leaving them in longer, we don't know yet. So how do we do it? We try to remove the tubes earlier. And this is how we do it. We got a 26 to 28 French drain placed in the diaphragmatic plane next to the apex, and another for a standard mediastainer. And when there's a necessary, we put a left pleural drains, and the pericardium will be continuous negative pressure of -8 to -10 centimeters of water. And we will make sure, if necessary for pericardiocentesis or torosynthesis, is confirmed by echo before and after the tube removal, and we will do the continuous post-op follow-up in the first 6 and 12 months. From what our data shows that there are more than half of the patients still have excessive effusions after 3rd days of the surgery. So basically, our mean drainage day is about 3.5 days. When there's 3.5 days, basically it means that the 4th day we take it off, because we don't do it in the middle of the night, and that's for sure. And after we did a PSM and to get the baseline characteristic between the two groups, we find that there's about approximately 23% of reduction of POAF in the delayed group. And so we define the POAF as a new onset of AFib within a year after the surgery in patients without any previous history of AF. And the occurrence of POAF is confirmed by either ECG or because we got patient monitored throughout their whole hospital stay. So if an AF period was a duration of about 5 minutes and the initiation of treatment of AF, such as amiodarone or electrical cardioversion, is what we consider this AFib, post-op AFib. And when there's a prolonged tube insert in the patient's body, what we worried about is infections. So from what we see that at least from about approximately a 3 to 4 days tube placing inside the patient does not increase the upgrade of antibiotic, meaning that possible there's not extra infections happening. And the pericarditis or the delayed secondary drainage is rather low with the way we set it, 100 milliliters per day. And we find that these patients that actually requires a second drainage, we got a longer stay. Approximately for our patients, same thing, we don't leave them in the middle of the night. So it's about 5 days for patients to discharge, and those with extra secondary drainage will cost for about 8 days. So you leave the tube longer doesn't necessarily increase the hospital stay. And the second thing for ERAS is we worry about when there's a tube, will it make them less mobilization. This is how we do it, even with sometimes when the patient is awake, if intubation, but it's not the time that we are ready to take off the tube, patients can sit up. And with all the tubes on, there will be nurses, there will be volunteers helping to let them walk around even in post-op day one, despite maybe sometimes they're weak, but still they can walk. And if without the chest tube, it's actually quite light with the continuous drainage from the pericardium. And another thing for ERAS is limited use of opiates. We worried about the pain problem when there's a tube inserted into the patients. So we set a numerical rating scale. I think everyone's familiar with it. 0 representing no pain, and 10 representing the worst possible pain, and to assess the patient. And the normal anesthesia that we are using is regional anesthesia during the surgery, and acetaminophen, tramadol, pregabalin, and gabapentin. When it's necessary, you can combine them, but try to avoid using opiates. And as you can see, actually patients in the normal group and delay group, I didn't show it here, but it's basically the same. The only thing that is different is that when the pleural cavity is open, when we are harvesting the lemur and we place in the pleural tube, it's causing much pain than the pericardial tube itself, at least from what we see. And so it's much more significant for a patient with a pleural tube. So in conclusion, for us, I think that delaying that will continuous drainage for the fluids and reduce POAF doesn't increase the post-op infection, and does not increase hospital stay. And without the opening of the pleural cavity, the patient is not that pain, and they can move around, and they can get hopefully a accelerated recovery. So this is all. Thank you.
Thank you for that. It's great to see the focus on drainology, something that you described being ubiquitous, but yet we have, I think, very little insight into what to do, but that's evolving pretty quickly, and we're excited about that. I think we're doing a good job staying on time, but I have to tell you a personal story. I've been waiting for this next talk for 30 years, and it started on a snowy night about 30 years ago when I lent Tom, who I mentioned, my car to use because it was a 4-wheel drive, and it resulted ultimately, that trip and so forth, in our next speaker, Alexandra, his daughter. I think parenthetically, if I remember the story correctly, 2 people held her before I did, Tom and Tracy, but I was the third. So excited about this. It's a small world that we live in, and it's great to see her.
Thank you, Dad. Thank you, Uncle Kevin. Good morning. Thank you all for being here, and I'd like to thank the organizing committee for inviting me, the token cardiology representative today, to talk to you about a topic I'm very interested in, GDMT in CABG patients with a low ejection fraction. I had the honor of working on a project related to this topic with Dr. Daniel Engelman, who's the current president of the ERAS Cardiac Society, with the idea of proposing a further collaboration between cardiology and cardiac surgery in an effort to improve patient care. I have no disclosures. So to set the stage, I want to talk a little bit about heart failure first. This is an international hurdle that currently plagues about 60 million patients worldwide. Focusing it down into the United States, where I currently practice, we have an estimated 6.7 million patients who have a diagnosis of heart failure. And the number of patients is steadily increasing, almost going to be doubling by 2040. And on top of the prevalence increasing in heart failure, we're also seeing rapid increases in heart failure admissions. Across the decade between 2008 and 2018, it was noted to have a 240% increase in this. In hospital admissions. For today's talk, just noting heart failure is a spectrum of disease, and there's many different ways to classify them, or classify it. I would like to focus the talk on heart failure with reduced ejection fraction, which is defined as a left ventricular ejection fraction of less than 40%. And when we look at the Society of Thoracic Surgery's national database, what we can see is that patients undergoing cardiac surgery in the patient cohort, about 25 to 30% have a preoperative diagnosis of heart failure. And that when we look at ejection fraction specifically, about 15% of patients undergoing CABG have an EF of less than 40%. And that's not an insignificant number. So looking at our ACC and AHA guidelines, when we look at specifically for surgical intervention, it is currently a class 1 recommendation in ischemic cardiomyopathy patients should they have an EF of less than 35% and suitable coronary anatomy. They should be considered for surgical revascularization because of the benefit from a mortality and a morbidity standpoint. But obviously, I'm not a cardiac surgeon. I'm a cardiologist. And so what I want to talk to you a little bit today is about the pharmacologic benefits related to guideline-directed medical therapy, which is currently the cornerstone of therapy for heart failure with reduced ejection fraction. The guideline-directed medical therapy is comprised of 4 pillars or 4 classes of medications that currently includes beta blockers, renin-angiotensin system inhibitors, which at this point includes ACE inhibitors, ARBs, and more notably ARNI, angiotensin receptor neprilysin inhibitors, mineralocorticoid antagonists, and lastly, the sodium glucose cotransporter 2 inhibitors. Each of these medications has been found in large randomized controlled trials to have mortality and morbidity benefits for patients and been found to have decreased rehospitalization rates. So why do cardiologists care about GDMT? It saves lives. So this is a paper that was actually just published in JAMA Cardiology in October this year and sought to answer the question, if GDMT were being optimized appropriately worldwide, how many lives could be saved? And that answer is about 1.19 million lives saved per year. So this is a huge opportunity. But not only is GDMT saving lives, it improves quality of life for our patients. So this was a study that showed when patients had changes or optimization in their GDMT over serial reevaluations, they were more likely than the patients who did not have changes in their medications to have stabilization of their heart failure symptoms or actual improvement of their heart failure symptoms. And that was related to an increase in their Kansas City cardiomyopathy questionnaire. Despite all this robust evidence that GDMT has this opportunity to improve our patients and their longevity, unfortunately, we're missing the mark. So this is data from the CHAMP-HF trial from 2018, which simply is just showing an outpatient registry of HFrEF patients and showing that these patients who are indicated to be on these medications are not on these medications. From this trial alone, what they found was that only 1% of the patients in the registry were prescribed all the pillars of GDMT at target doses. And now there's many reasons why this implementation gap exists, but there are concerns from the cardiology community because of inability for patients to access subspecialty care and other healthcare providers' unfamiliarity with GDMT. And so that's led to this paradigm in heart failure management. And specifically, along with all of the changes that we're pushing through from a cardiology perspective, there's actually been evidence to show that GDMT is both safe and efficacious with rapid titration on an inpatient setting. And so from a cardiology perspective, we're working on producing lots of papers and images like the one you're seeing here to encourage providers outside of cardiology to have resources to implement GDMT when patients come in contact with the medical community, and then make sure they're having cardiology follow-up. And so now I want to talk a little bit about each of the classes individually. So we'll start with beta blockers. The 3 beta blockers that confer mortality benefit for patients with HFrEF include metoprolol succinate, carvedilol, and bisoprolol. Obviously, you are all familiar with this. We've just talked a little bit about ERAS standards with starting beta blockers to decrease postoperative atrial fibrillation. These medications decrease heart rate, blood pressure, while also decreasing myocardial demand and contractility. Looking again at our heart failure guidelines, it is a class 1 recommendation for HFrEF patients to be put on these medications. Looking at just briefly some of the data related to this is from the MERIT heart failure trial, and essentially patients who were randomized into the metoprolol succinate group versus the placebo group. There was a relative risk reduction of about 34% in all-cause mortality in the metoprolol succinate group, and a 49% relative risk reduction in death due to worsening heart failure. Next, we'll talk about the renin-angiotensin system inhibitors, which includes 3 classes of meds at this point. There are ACE inhibitors, ARBs, and more notably, the ARNI, which only has 1 medication in this class, sacubitril/valsartan or Entresto. These are antihypertensive medications that also decrease sympathetic nervous system activation and also have an effect on myocardial fibrosis and an anti-inflammatory component. These medications have also been found to improve kidney function and the endothelial system. Again, so looking at our heart failure guidelines, it's a class 1 recommendation to put a patient on a RAS inhibitor. Specifically, the preferred agent is ARNI, or sacubitril/valsartan at this point, due to its superiority to the other 2 classes. However, if a patient is intolerant to ARNI, they should be put on an ACE inhibitor or an ARB, and that is still a class 1 recommendation. So looking first at ACE inhibitors, which is the oldest group within the RAS inhibitors, this is the SOLVE trial that randomized patients to enalapril versus placebo, and in the enalapril group, there was a 26% relative risk reduction for all-cause mortality or hospitalization for worsening heart failure. There was also a 22% relative risk reduction for deaths related to progressive heart failure in this trial. Then they were able to compare ARNI, or sacubitril/valsartan, to the ACE inhibitor enalapril in the Paradigm heart failure trial. And what they found is that with test drug LCZ696, which we now know as sacubitril/valsartan, there was a 20% relative risk reduction in the primary outcome, which was a composite of death from cardiovascular cause or heart failure hospitalization. Next are the mineralocorticoid antagonists, which at this point include spironolactone and eplerenone, another antihypertensive medication. They both work at the kidney and decreasing sodium reabsorption, but they've also been found to have profound anti-inflammatory components by decreasing oxidative stress as well as vascular and myocardial fibrosis that pertain to the heart failure pathophysiology. Again, it's a class 1 recommendation to put a patient on a mineralocorticoid antagonist. However, it has to be with a permissible renal function and serum potassium level. This is from the RAILS trial, which randomized patients to spironolactone versus placebo. And in the spironolactone group, there was a 30% reduction in all-cause mortality and a 31% reduction in death from cardiovascular causes. And what's important to note is specifically in this study, there was no significant increase in the spironolactone group of renal injury or hyperkalemia. And lastly, our newest class, the sodium glucose cotransporter 2 inhibitors, or the SGLT2Is. These were, at this point for heart failure, includes empagliflozin, dapagliflozin, and sitagliflozin. A mouthful, I know. And so just to note, these were initially anti-diabetic medications that enhanced glucose secretion through through the urine. However, they've been found to have a profound effect for heart failure patients. And the mechanism of benefit is still a little bit of a mystery, but it's thought that with this enhanced natriuresis, you're not getting RAS system activation, and so then there's also this possible anti-inflammatory component, and it may or may not be affecting cardiac myocyte metabolism. The benefit for heart failure is regardless of diabetes status. So it is a class 1 recommendation for a patient with HFrEF to be put on these medications, again, regardless of their diabetes status. And so the last trial I'll go through with you is the EMPEROR-reduced trial, which randomized patients to empagliflozin versus placebo. And in this study, it was found that the empagliflozin group had a 25% relative risk reduction in the primary outcome, a composite of cardiovascular mortality or hospitalization for worsening heart failure. And so I've talked to you a little bit about each of the individual trials related to the GDMT classes, but what's even more important to note is that evidence shows or suggests that the more classes that a patient is on, there's a synergistic effect not only from a mortality and morbidity effect, meaning the more classes you're on, the more benefit you get, but there's actually increased tolerance to some of the other medications with the more classes that you are on. And so this has changed the way cardiology is pushing these medications from an implementation status, where now we focus on saying we'd rather have you on some dose of more classes of GDMT rather than higher doses of only a few classes of GDMT. And this is just further data from a large meta-analysis related to pharmacologic HFrEF therapy, which again is showing from these forest plots that patients who are on the ideal or optimum GDMT regimen, which includes sacubitril, valsartan, beta blocker, MRA, and SGLT2I, are going to have further benefit from cardiovascular mortality and heart failure hospitalization perspective. And so why am I talking to you about this? I think the more important part is that heart failure is an extremely complex disease with rising prevalence, worsening heart failure hospitalizations, and it requires a large team to take care of these patients, especially when we have many millions of patients both in the US and worldwide, and only a couple thousand cardiologists to take care of them. And in certain patient populations, specifically ischemic cardiomyopathy, the cardiac surgeons are just as important as the cardiologists in taking care of these patients. And if you've heard nothing more from this conference today, I mean, cardiac surgeons are clearly striving to enhance healthcare quality and surgical outcomes by following evidence-based standards. And although what I'm talking to you today about is not directly surgical, I have shown you some of the evidence for GDMT from a medical perspective, and then reviewed the standards of care from a medical perspective. And so what I'm inviting the cardiac surgery community to consider is to join cardiology in this challenge against this implementation failure, in this failure from the healthcare system to treat our patients appropriately. And the idea being to focus on both preoperative and postoperative implementation of GDMT, which possibly together is obviously not going to just improve the longevity and morbidity of our patients, but may actually affect operative outcomes as well. And this is an area that has not yet been explored with research. And so this is just the central figure from the project that I was mentioning earlier. This was published in the Annals of Thoracic Surgery this year that talks about the perioperative and postoperative implementation and management of GDMT. Within this paper, we also were trying to create a useful tool or reference paper for cardiac surgeons, and so we created the following table, which breaks down each of the classes of GDMT, talks about their starting doses, their target doses, and adverse effects related to each class, and I've highlighted several here that I think are important from a cardiac surgical perspective, given the niche clinical scenarios that you are encountering in patients postoperatively, such as postoperative vasoplegia, volume status, hemodynamic stability, and renal function. And so in conclusion, there's a significant proportion of cardiac surgical patients undergoing CABG who have a diagnosis of heart failure with reduced ejection fraction. I've talked to you about the strong evidence demonstrating improved morbidity, mortality, and quality of life for heart failure patients with GDMT, but we are still not meeting the demands of our patients today. Cardiac surgeons have the opportunity to further improve quality of life in HFrEF patients by not only using the current surgical techniques and skills that you have, but by considering even being more aware of GDMT in the perioperative period. And if you've gotten nothing else from my topic, I want to let you know that heart failure cardiology is your friend. And if you aren't comfortable using these medications in the postoperative period, we would be happy to help you at least try to get patients on what they can before safe discharge. And all of these patients absolutely need a heart failure appointment within 7 to 10 days of discharge. Thank you.
That was worth waiting for.
Wow, I learned a whole lot today. It used to be a lot simpler just with ACE inhibitors and Lasix, and actually Lasix is nowhere in the paradigm today. So moving from heart failure to potentially another unexploited and potentially a neglected area in cardiac surgery, 90% of cardiac surgical procedures are done on pump. And I think that we take the pump platform for granted. And I think in terms of innovation, I think it may be rich to have a reapproachment or reassessment of what it is that the pump does behind us. Because again, what happens in the OR does not only stay in the OR, but has implications for patient outcomes. So with that, the next presentation is going to be what happens in the OR does not stay in the OR, presented by Mr. Isaac, Dr. Isaac.
Thank you very much. So from the token cardiologist to the token perfusionist. The only disclosure I will make is that none of these are my family members, but I did used to work with Professor Taggart down here in Oxford many, many years ago. And if you're surprised at seeing a perfusionist, imagine his shock at seeing this particular perfusionist in front of him. However, I have many roles, mostly in pediatrics these days, but I still do a bit of work in adults. I split my time between Great Ormond Street Children's Hospital, which is just about 2.5 miles up the road, University College London. But in more recent times, I've actually become the Chief Data Science Officer for Orem Clinical Analytics that's based in Michigan, and that'll become relevant in a moment. Now, this is going to be a talk that may seem a bit simplistic at first, but I liken it to driving a Aston Martin, which is just around the corner, by the way, out of London. This bit is all for posing, so you can actually see what we're doing, having a little look at it, and then we're going to get outside the city limits, and then we're going to accelerate quite hard. So bear with me. The future of healthcare, as you all heard, and this will fit very much into what you heard this morning, is that everything's becoming connected. We're getting far more data than we ever used to have. Now, whether that be smartwatches or, optical computer vision, as it were, all these different elements are becoming more and more common in healthcare. And there will be a time, and it makes sense, that actually you're going to get far more information from a smartwatch about what your blood pressure is, your heart rate is, than going to see your family doctor or general practitioner once every 6 months. It's just the way things are. And why is that relevant to perfusion or cardiac surgery? Well, we all talk about big data. It's something you've heard about. Well, big data can mean many things to many different people. But probably one of the things that you don't realize is that modern heart-lung machines actually put out an incredible amount of data at a very fast frequency. Most modern systems these days put out more than 200 different variables on a second-by-second basis. Now, when you've got that level of data, you're not really going to be able to use your traditional statistical methods to actually look at these things. And we've heard about clustering, we've heard about different ways that we can use machine learning, sort of supervised and unsupervised. Well, this is the level of data that we're dealing with, and those are the techniques that we're going to have to use. But what often happens is, and I don't mean to be, we talked about being cardiologists being friends to cardiac surgeons. I wouldn't go so far as saying we're friends with cardiac surgeons, but we certainly work with them in a collegiate way. And so when we turn around and say to them, look, this pump can do all these different things, the first thing they say is, that's great, well, you apply that and we get an answer. Well, that's not how things work. Unfortunately, the way that we get data from an AI algorithm is a little bit more complicated. It's not just data algorithm value. First of all, you've got to set up how you actually collect the data. What data do you actually want to collect? What is important? How do you then pipe that into a way that you can then look at it from many different institutions? So you've got a common data dictionary, if you like. How can you create something that is then validated across different units? But also, if you come up with an AI algorithm that says you should be doing this, how do you regulate that? How do you take something that is effectively a black box model that tells you how you should treat your patients when it goes wrong? Who's to blame? How do you put this into clinical practice? And that's one of those things that we don't know yet. It's one of the things we're trying to work out. But effectively, this is a long road that takes some time. And of course, as we've heard, AI is one of these things that people talk about without really knowing necessarily what it is. It can mean many different things in many different applications. And the level of your algorithm or your learning depends on what you are trying to achieve. It's always one of those things, I'm sure you've been in the same position I have. Somebody comes up to you and says, I've got a research project, which statistical test do I use? Well, what are you trying to do? Oh, well, I want to do this, I want to do this. Yeah, but you've not actually thought about it at the fundamental level of what are you trying to show? And this is the biggest problem that we have with machine learning and AI, is people don't really know what they're actually trying to do in the first place. And also, the landscape of research is changing within cardiac surgery. You're probably more likely now to spend your time analysing big data sets than you are to put on a white coat and go into a lab and do some practical work. That's just the way we're doing, because we have the ability to look at so many thousands of patients rather than just look at a particular vessel or something like this. So the way we're researching is being very, very different. And now this is not to give a plug necessarily to Orem, but this is the sort of architecture that you need to build up. And the idea of showing you this is that, if nothing else, I would like you to go back to your units, go back to your perfusionists and say, actually, it'd be great if you could participate in this whole process, because it's a long process, it is difficult, but once we get over those hurdles, the riches that we can potentially get are fantastic. And it's all about building relationships with different exhibitors that you've got outside, or the different manufacturers of heart-lung machines, getting that data out into a format that we can use it. So doing these pipelines, doing the data engineering, it sounds boring, and probably it is, but it's fundamentally necessary to what we actually need to do. And then once you get that, then you can start looking at those sort of sexy algorithms that say, I can do AI. Well, I can write a bit of computer programming, but that's what we're all trying to get to. And then the idea really is that you can wrap that whole process back. So rather than the traditional method of, I've written a research paper, I'm going to put it into a journal, and that journal is going to sit on the side and nobody's ever going to read it again. The idea of the AI algorithm is that you can say, well, instead of that, what I can do is then feed that loop back round to the practitioner, so it can be as a clinical decision tool or an advisory mechanism that sits with me on the pump that shows me how I should be treating my patients. But of course, all of these things need to be integrated with many of the different systems around the world. And if I can press on nothing else upon you, is go back to the different networks that you're involved in, especially if you're a cardiac surgeon, and say, do you know what, maybe just having bypass time and cross-clamp time in our outcomes doesn't tell us very much, because it doesn't. There are so many more things that we can learn if you actually have the data. The problem is, sometimes, and this was going back a few years, the centric view was more surgery rather than what was going on the pump, which is great, because if you don't ask questions about what we're doing, we can get away with anything. But that doesn't help the patients. So we need to actually work together in order to provide the mechanisms in order to treat the patients better. And the idea behind this is that hopefully someday, hopefully before I retire, we'll be able to take all the data. It doesn't matter whether it's metabolomics, proteomics, genomics. We can bring all this in as a patient. And what you will have is, when you go in to do your cabbage or your valve or whatever you're going to do, you will have a full report of the patient, so that we can sit down together and say, right, for these patients, these are the drugs you need, these are the flow rates you need, this is the oxygen level you need, because all these things are driven at the biological level. So why is that important? And what about, say, a sentence where you are still writing pen on paper, for example, on the perfusion records? We are missing out on a huge amount of data, and these machines are designed to capture that data. So why would you let it? And a great example was actually, this is accelerometry data from Bristol. If you don't take enough samples, you miss critical events that happen. You can see the difference between the two. So faster data collection, it does require more computing power, but it gives you the imaging, it gives you the granularity of the data that you actually need in order to make these things real. So let's knock it up a notch, and let's talk about machine learning within perfusion and some of the things that have been done. So this is a project I did a few years back with a colleague of mine. She was an MSc student, and this was in the pediatric sphere, but this was looking at oxygen delivery. You probably hear a bit about goal-directed perfusion and that idea. What should we be doing for our patients? Well, this is a group of just under 400 patients that we took, and we looked at, well, what is the sort of critical threshold for oxygen delivery that we need? You'll probably all be aware of the work by Marco Ranucci, and they said that 280 mils per minute in adults. Well, we essentially use random forest and some just basic logistical regression to actually work out that in pediatrics, that level is about 350. And it tails off over time. But that's fine, that's good. That's something that we can apply on a bigger data set than is normally achievable. But what you can do with this, and don't worry about the figures too much, but essentially you can look at the variable importance. So it's not only a case of what is that threshold, but what makes up that threshold? What are the important components within that we really need to know? But that brings us on to probably one of the challenges of perfusion and also for cardiac surgery in terms of how we do it, is what are these data based on? When Marco Iannucci came up with this 280 mils per minute, what does that look like? What is that underneath that threshold? Because surely the shape of that trough, of those, so we say, deviations below it, is more important than just total amount of time. Are you more likely to see it if you spend 20 minutes under that threshold in one go, or 21-minute dips? But again, we don't know. But also, if you think about what we term oxygen delivery, these are things that we're measuring on the pump. It's not actually oxygen delivery, not to the cells at least. All it's telling us is how well our oxygen is working, and how much blood rates it's going, and how much oxygen carriage effectively is going into the body. Where it goes in the body, how much is uptaken by the cells, and the cells are different in each tissue, and that can be in the same organ. Where is it going? What's it doing? That's driven by the oxygen dissociation curve. This isn't just it's just one value for the entire body. Things are different. And so what we started thinking about more recently is the case of, well, if that's not what we need to look at, and what we need to look at is what the patient's doing, obviously, well, how can we do that? We haven't got really a global measure of what the patient is really doing. But if we take the fundamental point of view that actually our bodies have developed over millions of years to essentially have an oxygen, or a metabolic demand, and a metabolic consumption, if you like, oxygen consumption, to match that demand. The way it alters that is through its oxygen extraction ratio. So perhaps rather than thinking about, well, how much oxygen we're putting in, is how is the body using that oxygen? How is it aligning its oxygen consumption to meet metabolic demand? And now, like I said, we're going to accelerate a little bit more quickly. And so now we go into the realms of actually, let's try some of the more complicated machine learning algorithms. So this is what they call a GARIX model, so a global autoassessive integrated model. So this is effectively a black box model that looks at it's a time window, effectively. So it moves across the whole amount of bypass time that you're doing it. And what we're doing is taking this black box model and we're adding this plus sign. And the plus sign just means that we're adding in things that we know are physiologically normal. So, and things that we are in control of. I say we as perfusionists, so flow rate, what the hemoglobin level is, what the oxygen level is, what our FiO2 settings are. These sort of things that we can manipulate, temperature, for example. And so what this is, a very complicated formula, is very basic, really, if you break it down. It's saying, at this particular point, where are we? On the seesaw of balancing, where are we sitting? And if we are going up on one side, how does the body bring that back down in order to get it level again? And if you can think of, go back to the sort of car analogy of driving this Aston Martin, you're going over a speed bump. Your springs are going to be like this, but you've got dampeners that will lower that down. So how is our body dampening the effects of what we do in order to reach equilibrium? And what we can see is when we started looking at this, so this is in just under 1,000 patients, we're looking at how long it would take these effects to essentially to wear off. So if you made a hypothetical change in your cardiac index, for example, how long would that take? And what we can show with these type of models is actually the effects last for about 7 minutes. So when we make a change, the body spends about 7 minutes trying to get back to equilibrium. Now, how often do we go on bypass and you say to the perfusionist, I'll drop the flows, or come back up on the flows, or do this, do this. If you make multiple different changes, all of these things are going on simultaneously. And the body is trying to react, not only to what changes you made now, but also the changes that have happened beforehand. And so you have this almost sinusoidal wave of how the body is dealing with it. So why is that important? Well, it gives us a bit of a clue about how the body works in terms of that physiology. Is that what you can see on the right-hand side is this sort of fast adaptive response as the body tries to then swing back by adjusting the OER effectively to match up with its oxygen demand. And then over time, as these things stabilize, it then has a very slow adaptive response that can last for many hours as it tries then to establish itself as a new baseline. And what's really interesting with this is then if you go a step further and think, well, actually, we all know that there's the idea of oxygen demand and oxygen delivery. You have the elbow or piecewise model in terms of you have oxygen supply dependence, effectively, that comes about. So once you reach a certain threshold, you don't need to worry about oxygen. You are extracting whatever you need. That's what we've been taught for many, many years. And it's based off actually 2 data points. The one was done in 1960, one was done in 1998 on a model that used sheep and a model that used humans, which can't be repeated for obvious reasons. But actually, when you look at this, and this is in granular data, so this is looking at minute-by-minute changes to a threshold in terms of its oxygen extraction ratio. So these aren't just 2 experiments. This is minute by minute over 300 minutes of bypass. And what you're seeing is that the actual changes you get, first of all, you have this proportional change. So if I increase my cardiac index, I'm going to supply more oxygen. The body is going to consume more oxygen. So you're going to have this period where you actually have the facility to have over-oxygenation in these patients until they then adapts, brings back the OEI in terms of matching up its oxygen demand and oxygen consumption. And if you run this model for long enough, what you end up with is the piecewise Elbow model that was first established back in 1980. So we can show that this is coherent with our understanding of what we've been taught a long time ago, but effectively using new data and the finer granulated fidelity data that we have shows that actually that piecewise model occurs over time, but is not the first thing you see. And so what we've got is the ability to then say, well, let's add in temperature into our mix. So for these patients where we have to cool down, now I appreciate that hopefully you don't do many coronary artery operations down at 18 degrees or anything, but there are occasions when you will have to cool the patient down. Whereas we've been taught that you will have a linear line in terms of where your metabolic demand increases with temperature, actually that's not what we're seeing. And that line is actually slightly different. And there is potential for under-oxygenation at lower temperatures and over-oxygenation at higher temperatures. It might seem counterintuitive, but if you thought and took that graph on the right-hand side and turned it into a sinusoidal curve, it becomes far more like a Michaelis-Menten enzymatic curve, which when you think about it, is what metabolism is. And it's more likely that actually what you've got is the ability to accommodate a certain level of temperature independence, if you like, in your enzymes. So when you cool down from, say, 37 to 32, your enzymatic function doesn't really drop off that much because that's what enzymes have. They have that ability to work over a range of temperatures. But as soon as you drop off, and probably below 30 degrees, that tails off quite significantly with function. So you then get this bigger drop. But of course, you then reach a point where it can't go any lower. So then you will tail off, which is a typical enzymatic curve. And I think once we look into bigger data sets, so we're now working on several thousand patients instead of just 1,000, even though that's quite a lot, we're more likely to see that sinusoidal curve, that Michaelis-Menten enzymatic curve in our patients. But what this means is it fundamentally challenges the concepts that we've been taught. This Q10 idea that you have a linear function between temperature and metabolism doesn't work. And we can see this in our patients. If you split them at about 28 degrees, by those sort of more hypothermic temperatures, what you see is the rate of increase is dramatically different. So there isn't a one-size-fits-all. These things change with temperature. It depends not only on your temperature, but also your patient's age, the underlying conditions. So what we're getting towards now is an understanding that we can look at each other as each different patient as an individual. And what I hope to do in the future is to bring this up as a almost precision medicine ability, but within perfusion. So hopefully, once you sit or you stand with your back to the perfusionist, you know that they're actually doing something that's particular for this patient rather than as a general view of what's going on. But what that allows us to do then is to then go back to this idea of oxygen delivery and say, well, okay, we know we can only control that. What the patient does is kind of up to them. But what we can now do is rather than just say it should be a curve where you shouldn't go below 280 degrees, what you're looking at is what depends on the temperature. And that also within the organs themselves, they will have different OER natural ratios. So you can now look at the different organs themselves and say, actually, for these organs, this is the cutoff that we should be looking at, not just 280 for everybody. And then when you start working that up, you'll see that actually these things do change and we need to have an adaptation of how we work with our perfusion systems. And that will bear fruits, I believe, as we go forward, because when we look at all the data that's collected by the heart-lung machines, there's a lot of other things we can look at in terms of not only power outage, in terms of, well, are we getting resistance from the pumps? Do we see a difference that's going ahead? Is the body changing, and can we see that mechanically within our systems? And then can we design the pumps, can we design the oxygenators to actually fulfill these gaps that we don't know about simply because we cannot identify them by using pen and paper on our paper charts. And we're using other models now, which are what they call federated data learning. So we have now got systems where, for example, in Germany, in the States, we have essentially 2 mirror images of different, or essentially the same databases, so that we can say, well, we know the rules around the country and around the world are different in terms of what you can do with data, where the data can go, but we can use essentially the ability to send the question rather than send the data to answer these things across multinational different trials. We're working with our colleagues in Australia in order to bring them on board. And so within sort of 5 years, you're going to go from having the ability to look at 100 patients to then 100,000 patients, very, very simply, because they're all going to be based on the same ideas. And that hopefully will give us some more insights into how we should treat these patients and give us the ability to modernize and personalize our perfusion practice. Thank you very much.
Thanks for that. Insightful. This next, I guess it's initial appearance would seem simpler. We often hear always, never when it comes to things like PA catheters, and I would suggest be very suspicious of that type of thinking. Specifically, when you hear PA catheters associated with death and that sort of thing, it's very simplistic look. But Luke Perry comes from Australia, and he'll shed some light on this concept and hopefully teach us how to optimize our use as opposed to being categorical about always or never. So.
All right, token anesthesia resident reporting in. I'm here to tell you about the good, the bad and the ugly of pulmonary artery catheters and explain how patient selection can potentially enhance recovery after coronary surgery. So my name's Luke Perry. I'm the head of research at the Victorian Heart Hospital with the Department of Cardiac Anaesthesia. I'm also an anaesthesia trainee, like I said, and currently completing my PhD in pulmonary artery catheters under Professor Ronaldo Bellomo, who's here, and that's our head of surgery, Jamie Bennett, and anaesthesia, Andrew Silvers. So today I'll be presenting insights from 3 unpublished studies and giving you a state of the evidence on pulmonary artery catheters in coronary surgery. I'll also be introducing our clinical trial called PUMA, which will provide hopefully some world-first evidence from randomised data on this issue. I want to give my warm thanks to the organising committee, and in particular I want to thank Thomas Schwann, who around 20 years ago in 2002 published this beautiful and prescient paper highlighting the safe but highly selective use of pulmonary artery catheters in a large series of cases. I wonder if back then he'd believe me if I told him his work would still be very controversial 20 years later. So let's start off with some good news. Where else can you get all of this data in one place? Pulmonary artery catheters provide unique information about the right heart and the pulmonary circulation in real time, multimodal, multi-system physiologic insights that can be used to guide treatment decision and assess the severity of illness. And we know that at least some of this data generated by pulmonary artery catheters is prognostically significant. My team recently completed this study of over 6,000 coronary surgery patients managed with a pulmonary artery catheter, and we aim to map the association of the lowest cardiac index with 90-day mortality. We used entropy balancing, which is a type of causal inference method, to adjust for over 20 confounders. The striking features of this curve are the plateau here in this borderline range between 1.9 and 2.3, and the steep inflection point as we get below 1.8. This is actionable data from a pulmonary artery catheter that can be used to guide inotropic support and other treatments. Now, I have to admit that my group also recently published a systematic review on pulmonary artery catheter use with Mario Gaudino that showed increased mortality with their use. So imagine our surprise when 2 months later, this large Korean national database study of over 60,000 patients was published in CHEST, a very good journal, by Dr. Jae-woo Ju and colleagues, which showed a dramatic reduction in 1 year in operative mortality. And this is the first study that I'm aware of to ever show a mortality benefit associated with pulmonary artery catheters, possibly because such a finding has got to swim upstream against the deluge of unmeasured confounding in these database studies. Interestingly, the effect appeared largely driven by coronary surgery, and particularly off-pump cases. You can see here in the forest plot had the best outcomes. And as well, quite interestingly, low-volume centres seem to have the best outcomes with pulmonary artery catheters. This study should promote some degree of equipoise, and the potential to reduce mortality is alluring. Time for the bad news. We all know that the accuracy of the thermodilution cardiac index is influenced by things like intracardiac shunts, injection technique, where you're at in the respiratory cycle, catheter position, and tricuspid regurgitation. But I bet some of you are not aware of just how high the degree of intrinsic error and imprecision were in these techniques. So here in this table, precision error refers to the minimum change in the real cardiac index between separate readings required to be acceptable as a genuine change, or if you like, a statistically significant change. This can be improved by measuring in triplicate and removing outliers, but this is not painting a great story. It's also worth noting that emerging technologies, including those using continuous cardiac output and machine learning, could improve on accuracy and precision. So here's our team's recently published systematic review that I alluded to. We included 7 studies of over 25,000 patients and observed an association of PAC use with an increase in operative mortality with an odds ratio of around 1.6. There was also a trend towards increased complications, more inotrope use and longer stays in the ICU. Now I'm going to talk a little bit on the potential for overdiagnosis and overtreatment of abnormal physiology, particularly in our low-risk cases. So this is a recent large single-centre retrospective cohort study evaluating over 10,000 patients from Beth Israel and Boston that my group also did. We again used entropy balancing to adjust for confounders and tested for the association of PACs with a range of clinical, but this time mechanistic outcomes. And for the primary outcome of 90-day mortality, you can see we had quite a large association before adjustment. And after adjustment, this observation dissipated completely. There was also a general trend towards increased complications like acute kidney injury and higher intensities of perioperative treatment, including this TPOD7 number, which is the cumulative time spent on at least one organ support, including mechanical ventilation, a vasoactive infusion, mechanical circulatory support, or renal replacement therapy. So a pretty consistent trend with things like doses and peak doses of noradrenaline or norepi equivalents, transfusion, fluid balance, and the like. One of the coolest findings out of this study was a significant increase in the ICU length of stay of about 1 day. It's probably a bit hard to read, but this is a density plot showing a 1-day increase in the mean ICU length of stay with pulmonary artery catheters without any change in the hospital length of stay. So this suggests that patients in this group are spending a greater proportion of their admission in the ICU without affecting their overall rate of recovery. And if you remember from the previous slide, the time spent on any one organ support, the time difference is only 10 hours. So patients managed with a pulmonary artery catheter had an extra 14 hours spent in the ICU, not receiving any ICU level organ support. And this finding highlights, I think, the potential for delayed decision-making around ICU discharge when there's a pulmonary artery catheter. Now for the ugly, and this is TUCO. So our guidelines on pulmonary artery catheter use lack teeth, and we've also seen in an earlier talk the 2024 ERAS guidelines, which were consistent with these ones here. So these date all the way back to the 2003 ASA Task Force on Pulmonary Artery Catheters, and the recurring theme is that there's low quality evidence, no trials, and that pulmonary artery catheters may or may not confer a benefit in selected cases, and they've all called for an RCT. Here's some more unpublished data from my group. We analysed over 200,000 cases in Australia and found major variation in practice between states, with Victorians being about 20 times more likely than Queenslanders to be managed with a pulmonary artery catheter. International surveys in Western countries and developing countries have shown significant degrees of variation, with PAC rates ranging from about 15% up to 90+%. It should also be acknowledged that intensivists are making us look bad. Large international practice-changing trials have successfully been conducted in other patient groups with a signal towards worse or no difference in mortality and increased complications. The global critical care community responded to this overwhelming evidence with a large-scale de-adoption of PACs in other patient groups, with their rates dropping 70% through to the year 2000 and a further 70% from 2000 to 2013. Meanwhile, we're basing our practice on retrospective observational studies and clinical knowledge. This should leave you feeling a little bit like this. I should also add that PACs are capable of causing rare but catastrophic iatrogenic harm in about 1 in 1,000 cases. This can include pulmonary artery rupture with endobronchial hemorrhage, RV perforation, pulmonary infarction, which is getting less common now that we're wedging less, and life-threatening arrhythmias. And at my own centre, we've sadly had 4 deaths in 10 years due to PA rupture, which potentially preventable. So this may be controversial, but I believe that limited and highly selective, rather than routine use of PACs, particularly in low-risk cases, could promote enhanced recovery, and this could be mediated through the avoidance of overdiagnosis and overtreatment of abnormal physiology, reduced complications, and shorter stays in the ICU. So to summarise, there is a mechanistically plausible signal that PACs result in higher intensity treatments and delayed discharge from the ICU. The general quality of the evidence is low and mostly comes from retrospective database research. There are no randomised trials to guide practice, which remains highly variable. The drumbeat is becoming increasingly loud that we don't fully know what we're doing with these things, and the only way to address this is with a large randomised trial. My lab is currently working towards that goal with international collaborators. Our 150-patient pilot and feasibility trial is called PUMA-1, and it's enrolling adults undergoing low-risk cardiac surgery to determine the feasibility of a definitive trial and also to explore some clinical outcomes. Recruitment has far exceeded our expectations, and we're on track to recruit our 150th and final patient within about 6 months this January. We've made history at several Australian sites, which are 100% pulmonary artery catheter usage rate sites, by safely managing over 60 patients with just a central line and causing no reported issues. If you'd like to get involved in the definitive trial, please reach out to me here in person or send me an email. And thanks for your time this morning.
So we're almost back on time. We will finish up this session with our last abstract entitled Enoxamine Administration to Improve Renal Function in Cardiac Surgery, Final Results of Multicenter Observational Study with Enoxamine in Cardiac Surgery Study. Thank you.
Good morning, everyone. Thank you very much for the introduction and invitation to speak here. Today, I will be talking about a study we did titled Enoxamine Administration to Improve Renal Function in Cardiac Surgery. So, starting with a little bit of background, we know that the post-operative renal failure can be a major issue in cardiac surgery, which is strongly associated with the cardiopulmonary bypass use and its duration. So many strategies have been proposed to reduce this risk, such as the off-pump surgery, the miniaturized CPB, and the use of the anti-inflammatory drugs. Therefore, the aim of our study was to assess the impact of the enoxamine on renal function in patients undergoing on-pump cardiac surgery. So, but how does it work? Enoxamine is a selective inhibitor of the phosphodiesterase 3 with a vasodilating and positive inotropic effect that, however, does not change the myocardial oxygen consumption. So this enzyme's inhibition prevents the degradation of cyclic GMP, which leads to an increased nitric oxide release and vascular relaxation. This cascade of events leads to modulation of the hemodynamics and reduces the inflammation. So this was a multicenter observational study with enoxamine in cardiac surgery, as known as MOSAIC study, and the preliminary results have been already published in 2018, and we have implemented the cohorts of patients, prospectively enrolling patients scheduled for on-pump coronary bypass grafting surgery. And the exclusion criteria were the preoperative severe renal failure, defined as eGFR below 15 or the need of dialysis, the preoperative liver disease, history of alcohol abuse, and sepsis. So the renal functions was preoperatively assessed, estimating the glomerular filtration rate using the CKD-EPI equation, and as well the CKD class was assessed before surgery, as we can see here on the right. And the post-operative evaluation was also assessed calculating the eGFR and its delta at day 2, 7, and 30 post-operatively. Renal failure was defined as more than 50% decline in the eGFR from baseline or the need of dialysis again. So this study included in the end 232 patients that after the propensity score matching ended up in 2 cohorts, including 160 patients each with the characteristics we can see here in the table. So there were no significant differences in the delta eGFR evolution in percentages at day 2 and 7, as we can see here on this table. However, at day 30, we can see that patients undergoing enoximab administration had an improvement with a 5.1% in the delta eGFR evolution compared to the decrease of minus 3.9% in the control group. So this slide shows the changes in the CKD class from the preoperative and the postoperative period. As we can see in the plot on the left, patients undergoing enoximab had more improvements, since more patients changed and went up from class 3 to 2 and from class 2 to 1, compared in the control group we can see on the right, where either the patients stayed in the same class or had more worsening compared to the other group. And these improvements was significantly different between the 2 groups, as roughly 26% in patients undergoing enoximab administration improved compared to the roughly 14% of patients in the control group. So to investigate factors independently associated with the change in the delta eGFR at day 30, since it was the significant one, we performed a multivariable renal regression that showed age, BMI, preoperative eGFR, of course, and the use of enoximab, most importantly, to be positively associated with the delta variation at 30 days. There were no significant differences in other early outcomes, such as early mortality and other mechanical support. The only difference was found in the inotropic drug use that was higher in the control group as expected. So, however, this study needs to be seen in its limitation, of course, which most of all the lack of randomization that can lead to risk of selection bias and all the interaction that the enoximab can have with other medication as well. And although we don't know the exact mechanism underlying the positive effects of this drug, we can assume that the positive inotropic and vasodilatory effect could explain its benefits in the type 1 cardiorenal syndrome, and its inflammatory modulation could explain its benefits in the type 3 renal cardiac syndrome. So we can say in conclusion that this study found patients undergoing on-pump coronary artery bypass grafting may benefit from the perioperative enoximab treatment. The renal function significantly improved at 30 days in the enoximab group. However, the patient selection remains crucial in identifying those who may benefit from this treatment. And thank you very much for that.
Well, that was terrific, and I think we all learned a lot. Really great presentations, and I think the moderators, Tom and I, conferred, and totally unbiased, but I think that Alexandra wins the best talk, don't you think, Tom? With that said, we are right on time. We want to keep people moving, but also give you time to ask questions. So maybe 3 questions from the audience, if not a little bit of debate from the panel.
Good morning. Great session. My name is Mark Bell from Ottawa. I'm sure everyone here has an opinion about PA catheters, so I'm just going to voice one, but every single one of us has one. I'd be interested in hearing what Rakesh and other eminent intensivists believe, but for whatever that's worth, I find, as you were saying, it's a lot of subclinical, dubious information that sometimes steers us away from how the patient clinically is doing. So that's one. And second, I wanted to add to the array of complications, because I think this is a surgical meeting. About 6 months ago, it's something I had not seen, and perhaps some of you have seen it, but I was on call, and one of my colleagues' patients was a young 42-year-old who had aortic valve repair and mitral valve repair, and was doing great, and it's 2 in the morning, and they take out the Swan Gans, because patient's cardiac output is like 3. And, it's not needed anymore. They're hoping for fast track and early discharge to the ward the next morning. So the nurse takes out the Swan Gans, and the patient goes in complete cardiac arrest. And we scramble, and we find basically that he's in tamponade. Fortunately, he responded to fluids. We can bring him to the OR. And in the OR, what do I find? As soon as I take the clot out, the resident actually doing the case, and I'm assisting him, takes the clot out, and the lower IVC purse string is completely open. The suture is cut, basically it's torn away, and there's a hole the size, in Canada we say a toonie, a $2 coin, which would be about 2.5 centimeters wide, open. So essentially, and fortunately, with cardiotomy suckers and everything, 2-3 suctions, we're able to put a suture on this because it's much bigger than any suction would be. And the patient actually walked out of the hospital okay. But essentially what had happened is when the other resident had put the suture, he had put the suture around the Swan Gans, right? And the Swan Gans was incorporated in the suture. So just be mindful of that. If there's a Swan Gans that's in there and you're doing, especially in IVC cannulation, and you're putting suture and your resident goes a little bit deep, that can easily incorporate the Swan Gans with catastrophic results. Just wanted to say. And again, I would love to hear the panel's thoughts about pulmonary artery catheters.
Yeah, I guess I'll start with that, and I'd love to hear, Tom, you've been studying this like everything that I've ever thought of long before I thought of it, and Rakesh also. But what I would say from my unique perspective is we have to think about it the right way. And there's no question there are complications that would be unique to, say, a PA catheter that you're not going to get from a radial arterial catheter that gives you some waveform analysis. But beyond that, I think it really depends on who's managing the patient and what do they do. And when I say that, it's one thing for somebody with a lot of experience to manage a patient with less invasive monitoring, and then a different thing for somebody with a lot less experience. In the example that I would use there is the congenital world. If I got $1 for every time somebody told me a kid had great pedal pulses or his toes were warm or something like that, I would have retired a long time ago. So I think you really have to know who's doing it, and again, what do they do with this information? So that said, Tom, Rakesh, what do you think?
So just a comment regarding, your anecdote, Mark. Been there, done that. So we know that the pain that's associated with it. And even if you take a very superficial bite, potentially when you have a PA vent. So we routinely, and we've had encountered a similar issue that the PA pulled a catheter and all of a sudden we have massive bleeding. So before we leave the operating room, anytime that we doubly cannulate or put anything in the PA or repair the PA, anything on the right side, we as the anesthesiologist make sure that the PA catheter is freely movable before we leave the operating room as an additional safety measure. In terms of using these PA catheters, I think that, there's a lot of physiology that we do not understand. We have a global assessment of SVO2, right? It's a summation of all of the microcapillary beds that feed into the pulmonary venous return, systemic venous return. So we really do not know what happens in the various capillary beds. We don't even quite understand today, even though we're using the cardiopulmonary bypass machine for what, 40, 50 years. Very fundamental question. What is the optimal blood pressure for cardiopulmonary bypass? Is a mean arterial blood pressure of 80 adequate? It should be 70, should it be 90? Is a mean arterial blood pressure of 80 with inotropes or with vasopressors better than a blood pressure of 70 without them? And I think those are some of the issues that we are beginning to sort of tackle as we try to understand the impact of physiology on our patient outcomes. And a lot of this stuff, we take for granted, and we sort of think, what's going to happen there, what's going to happen in the ICU, who's going to take care of that ICU patient, synthesize that approach to hemodynamic management. Should it be automatized? Should it be protocolized? It still depends on the primary caregiver, i.e. typically the nurse, right, to incorporate these various data streams that come from the laboratory, that come from hemodynamics, that come from chest tube drainage, that come from urine output. How do you incorporate that? When does the alert go out to the physician that something is wrong? You have to recognize that there is a problem before you fix it. Could that be all automatized? Could we attach, artificial intelligence to help us with that? I think this is the need for this discussion here and the opportunities to think outside of the box and innovate. Because again, I think somebody said that yesterday, right? If you continue to do the same thing and expect different results, that's insanity, right?
Rakesh?
Yeah, so I think in just the interest of time, I'll make three shortish comments. First of all, to Dr. Perry, congratulations on trying to do a randomized trial. I think you're quite right. There has been very little data in cardiac surgery at all. And as usual, Australia and the Canadian Trials Group have been really leaders in developing really highly relevant, important topics, research initiatives that aren't necessarily funded by anyone. And so really congratulations for that. Two, I'd say as per Alex's talk, I think where I've relearned how to use a swan was really in the heart failure patient, and that's probably the patient population that I would use it the most. But going back to one of the studies that Luke presented with Dean Sandom's study from 2003, he was my attending at Calgary when I was doing my ICU training, and there was a survey at that time when you took very highly qualified intensivists and had them interpret the Swan-Ganz catheter waveforms, and about 40% got it right. It's a little less than a coin flip. So I think as we now go to about 10% or less in a lot of centers using swans, the amount of experience and when to use it and how even to set it up in our unit is quite impactful. So I'm even less clear as we've gone on whether it's of value to me, and as we have newer non-invasive tools that can be used pulse width waveform to give very similar data. I don't know the PA catheter is relevant in all cases, but there are some that you need it. And I don't know that I still have, after doing this for 20 years, know the kind of patients are going to need it until I need it. Which is very unhelpful, Mark, I realize, but that's sort of where I'm at right now.
Yeah, I think it depends, but maybe one of the ties that binds all of this, if you think about like the work that Omar's doing or what we heard about perfusion and that sort of thing, is more comprehensively aggregating data, analyzing it, and looking for correlations. An example might be, say, in the drainology space, if somebody 30 years ago would have been trying to tell me that somehow the chest tubes were associated with atrial fibrillation, I would have thought they were out of their mind. But I think that the longer we're on this journey, the more we realize that we don't understand how all these things may or may not interact, right? Here's another unique perspective. We're probably more like Victoria in that we more commonly or by default use PA catheters. And just reviewing a subset of that we've remotely monitored, much like you're involved with, Omar, 1,715 patients in the first 5 years of that experience, and we had one death in the coronary plus valve. So if we use PA catheters in all those patients and we had those results, I'd challenge somebody to do better, but I'm sure there's somebody going to say you wouldn't have had that death if you didn't use PA catheters, right?
Yeah, I think one other small comment, I'll say that the graph you showed of the distribution across Australia and its utilization, I have that little microcosm in our 5-hospital system that one site has almost 100%, the other one has almost 20%. The lowest risk category patients always have swans. The highest risk patients very rarely have swans. I don't think we know what we're doing with them even now. So I'm really interested in what your study shows.
Yeah, a pragmatic way to look at that sort of thing too is you have to decide if you want to take that on, whether it's in a country or a system. What I've learned is you want to get some early successes, whether it's enhanced recovery or one specific element that you're trying to change. And oftentimes those may not be the things that are, divisive that you want to tackle first. So a word to the people out there that are looking to lead change. I'd say start with easy things that everybody can more or less agree on and work your way towards those things that are more challenging. Tom, any final thoughts or questions?
I guess the final question final comment I would make is that, making sure that we assess a low flow state by clinical criteria requires much more, I think, insight and experience than the use of just hemodynamic data that's projected from the Swan-Ganz catheter. So it depends how experienced your APPs are, it depends how experienced your nurses are. whether you have an in-house critical care provider, whether that's long distance, whether that's monitored by telemedicine or what have you. So there is a whole host of opportunities here that need to be explored, defined, as we continue this journey to improve quality and enhance care for our critically ill patients.
Yeah, I think that's great. And maybe one additional comment is I was reflecting on something about this recently. I was thinking about like urine output and the early ground proximity warning system we see in planes, and that's great to have smart signals. But I think what we really need to get to, and Tom, you kind of alluded to this, is more like autopilot. So all of this information gets integrated, and it's not just smart signals, but it's actually the associated therapy. I think in some way we are all aiming at that same thing, and it probably fits with what you've heard here today at the Congress and innovation. So thank you.